Okay, so today's topic is on mitral stenosis and treatment, and I think this is the difference between what we're going to talk about here. From conventional point of view, I will not be focusing so much on the techniques of doing mitral balloon dilatation, but mostly on the understanding of pathology and case selection. The scope of this talk from the point of view of pediatric cardiologists is purely I'm going to discuss rheumatic mitral stenosis, that is juvenile rheumatic mitral stenosis, and not congenital MS, because I think congenital MS is a very different disease altogether and has a very different treatment approach. So I think they cannot be mixed and they have to be dealt with in different sessions altogether. And the focus, as I said, will be more on case selection than technique. And I think techniques are learnt in the cath lab by scrubbing in for these procedures, because there are so many intricacies you will never learn unless you actually do it. So I'll not go through too much about the details of the technique, but the thinking behind the procedure is more important. And also knowing about the history is important, because a lot has happened in India. I think that's something that you need to get insights into. So little bit about medical therapy. Medical therapy of MS is intricately linked to physiology of MS. And I think that's the thing that needs to be understood when you treat, when you have to manage somebody until the procedure is done, or somebody is not suitable for balloon mitral valvotomy. How do you manage medically? There is nothing much to it, but the principles have to be understood very well. So if you start by looking at this tracing, it's important to recognize a few things. So this period that you see from here, mitral stenosis, pressure tracings of mitral stenosis. Kavita, please give me feedback if something doesn't show up. Quickly, don't be hesitant, and because the important thing about this slide is to look at the duration of systole versus duration of diastole. What you're seeing out here. This is a recording obtained at a relatively fast heart rate. Okay, so when you look at the duration of diastole, you realize that systole takes up a lot more time than diastole. So when you speed up heart rate, the phase of cardiac cycle that gets consumed more is diastole and not systole. So as you speed up heart rate more and more, the diastolic duration disproportionately shortens. As a result of which, the time available for the ventricle to fill is markedly reduced. That is what results in a great deal of exaggeration of the gradients during fast heart rates. So the primary focus in mitral stenosis is to slow down heart rate, and that's what's most effective. So the real aspect of treating mitral stenosis relates to trying to slow down heart rate, and traditional means used to be digoxin, but now you can almost always do it with beta blockers. You don't need to give digoxin, and beta blockers is sort of the mainstay of mitral stenosis along with diuretics. That is the key aspect of medical treatment. The other aspects of medical treatment relate to, of course, maintaining anticoagulation in those who are vulnerable to atrial fibrillation. So for juveniles, you don't start anticoagulation in sinus rhythm traditionally. But as you get into older patients, both for sinus rhythm and for atrial fibrillation, if you're not planning on anything definitive for the mitral valve and the left atrium is enlarged, there is a strong case for giving anticoagulation. So warfarin or equivalent is probably indicated, because the risk of stroke is substantially higher in mitral stenosis than with atrial fibrillation than just atrial fibrillation alone. I think it's got the highest risk of clot formation in the left atrium. Now I just wanted to show you a few additional slides in this context. Now, Kavita, are you able to see a different tracing now? Pediatric cardiologists understand the physiology and the correlation of physical findings, because this intuitive hemodynamic understanding is less amongst pediatric cardiologists than it is amongst people who are trained in adult cardiology. So if you want to see carefully, this is the V wave, Y descent. You can see that the Y descent is not complete. It falls short substantially of the ventricular diastolic trace, producing the early diastolic gradient. There's also a lag. You see this diastole, Y descent has got a slope that is different from the slope of the ventricular pressure trace, creating this gap which results in the E wave of the Doppler tracing, which I'll show you. But more importantly, this is the point at which the opening snap happens. So if you see this, this is when the valve opens suddenly, the onset of diastole, actually not onset of diastole, the onset of left ventricular filling. This is the point where which it happens. It's just after the isovolumetric relaxation. So this point, the valve opens rather suddenly. If you see carefully, this video when I play it, the valve opens rather suddenly at this point. And if the buildup of LA pressure is substantial, this valve opens immediately as soon as, so the A2-OS interval is rather short in that situation. So that is the opening snap, and this is the A2-OS interval that you are seeing. And that duration is inversely proportional to the severity. The valve opens, and you can see the doming valve that opens. So you can see this sudden downward movement that correlates with the opening snap. You can almost understand how the opening snap happens. This is a 3D echo seen from the bottom, where you can just suddenly see the snapping of the mitral valves. It just snaps open, and very important because the opening snap correlates with the pliability of the valve. It's an indicator of the valve is pliable. It's only if the valve is pliable that the sound is produced. And of course, then you have the rapid filling phase, which correlates with the Doppler. The Doppler, I told you, E wave, which starts because of the slope is different between the Y descent and the ventricular pressure trace, creating a E wave. And this particular slope, which you see with the filling of the early E wave, is proportionate to the severity. So it is the basis of calculation of the valve area using the pressure half time. So that is the correlate out here. And of course, then you have the A wave, which is happening because of atrial systole. And this is the Doppler effect, but essentially correlates with the mid-diastolic murmur with pre-systolic accentuation. So all physical findings of mitral stenosis have correlations with the pliability of the valve, the severity of the valve, the presence of sinus rhythm, etc., etc. So it's got a very good mirror as far as the patient's underlying pathology is concerned. So this all has a bearing in case selection. I'll tell you a story because you'll understand that. I've said it before, but it's very important to understand. So the treatment of mitral stenosis or medical treatment is very straightforward. Reduce the heart rate, give some diuretic, and ensure that patient doesn't develop a left atrial clot by giving some anticoagulation. And of course, penicillin prophylaxis is very important. We don't wait usually. Nowadays, with significant mitral stenosis, and again, that point of how significant a mitral stenosis is and what should be the indication for balloon mitral valvotomy is highly relative. It is completely related to what the patient undergoes. Severe mitral stenosis, there is no question. But when there is less severe mitral stenosis, we still will balloon a valve if the patient's lifestyle is limited. It's important to recognize the importance of body surface area. So we had a 6'7" gentleman with a valve area of 1.8, absolute valve area of 1.8. That's severe MS. So you have a traditional classification of 1 centimeter square per meter, not per meter square, actually absolute, not per meter square as the indicator of severe mitral stenosis. So recognize that it relates to the height of the individual and the weight of the individual. So we really had this Afghan gentleman who came not here in this hospital, who was 6'7". And he was severely limited, and people were fixated on the fact that the valve area was only 1.8 and not 1. And the important thing to recognize, it was producing lifestyle limiting symptoms. And somebody who's working, for example, I had an army man who was working and valve area was 2. but then he had to do extremely vigorous activity. So in that situation, it became important to recognize whether, we had to debate whether we had to open the valve or not. And eventually we chose to open it and make the valve area 2.8 because the valve was excellent, in terms of pliability, and the patient was relieved. So it's very relative, it's related to the patient's symptom status, and there aren't any absolute rules as far as mitral stenosis is concerned. But the general rule is severe mitral stenosis, 1 centimeter, but I would say 1 to 1.5 is definitely a region. Even below 1.5, we don't hesitate sometimes to open up the valve if the valve characteristics are very good. So the essence really is, either you manage medically until you have to decide about opening the valve. And opening the valve, stenotic valve, there are the options that are available to us are obviously surgery, which can be closed mitral valvotomy or open mitral valve commissurotomy. I'm not even putting mitral valve replacement as an option here, and I'll tell you it's very important as far as possible not to open up any mitral, not to resort to mitral valve replacement in any circumstance as far as possible. Catheter is either through balloon or through percutaneous commissurotomy, about which I'll just briefly mention at some point. Now this has got confined to history without a very good reason, closed mitral valvotomy. It's a bit of a sad story. Until 80s, this was routinely performed. Is it still routinely performed in Calicut Medical College? Closed mitral valvotomy? So when balloon was out of stock, they did a few cases. That's what I have a DM student from Calicut Medical College whom I'm asking this question. So in a medical college, it used to be the simple procedure that a general surgeon could perform, not a cardiac surgeon. So when I did my house surgeonship in surgery, I had a surgeon who could do the closed mitral valvotomy, a general surgeon, not a cardiac surgeon. And the procedure involved, if you see this particular lower graph, putting a finger through the left atrial appendage, feeling the mitral valve orifice, both the sides of the orifice, guiding the Tubbs dilator, which you see out here, Tubbs dilator, which is basically commissurotome, through a mitral apical ventriculotomy across the mitral valve, feeling the Tubbs dilator with the finger, all with the beating heart, guiding it and then opening it up. This needed technique, this needed finesse, this needed judgment, but it could be learnt, and it used to cost less than 1,000 rupees. It used to be free in my hospital medical college, but it costs very little because you can use the Tubbs dilator several times. Patient is not on bypass, it's a thoracotomy. But what happened is that the balloon came in. Once the balloon came in, the cardiologist started to do balloon mitral valvotomy. They wouldn't refer it to the surgeon. Surgeons lost the skill. The balloon cost 25,000, 50,000, 10,000. Depending on where it is done, it costs anywhere between 10 times to 20 times the cost of the closed mitral valvotomy. Closed mitral valvotomy results are outstanding, in good hands. To read the world's largest series from Vellore, published by Stanley John in Circulation in the mid-80s, the results are very good. But because the cardiologist took over, the procedure disappeared. And I think it resulted in the very large number of people in the world being denied of the procedure. This is particularly sad in countries in Africa or in really remote areas of our country, where we had the skills, we could still do this procedure. What has happened is that the balloon has replaced it. And we haven't done enough as cardiologists to reduce the cost of balloon, because it's so difficult to sort that out because there are so many overheads. But this is an important story just to recognize how procedures evolve in medicine, not necessarily in the best patient's interest. It's in our interests sometimes. Okay, pre-procedural assessment is very important. And I think the whole focus of this talk is pre-procedural assessment, because as cardiologists, the most important aspect of mitral balloon dilatation or closed mitral valvotomy or anything you do with the mitral valve is to know that the patient is a candidate for balloon mitral valvotomy. If you make a mistake here, that's when things go wrong in the cath lab. Because the valve, once you get a balloon across the balloon valve will open in a certain direction and you have no control over it. But if you select a patient wrongly and send the patient, the balloon is going to open the valve in the wrong direction. So it's very important to spend time and understand who's going to do well with balloon mitral valvotomy and who's not. Who's going to do really badly, don't send for a balloon mitral valvotomy. That's a relatively small proportion. Or be really careful with how you do the balloon mitral valvotomy. Okay, amazingly, I want to show you the story of clinical evaluation. As I told you, it's actually pretty good. You can actually predict the likelihood of success with a closed or balloon mitral valvotomy extremely well if you're an astute clinician. You can listen to the opening snap, listen to the murmur. If you have really good ears, you can identify mitral regurgitation. If there's an audible mitral regurgitation, then the patient is not a candidate. And usually the mitral regurgitation is significant, and you can quantify pulmonary hypertension, tricuspid regurgitation. You have to be sure that this patient doesn't have bad pulmonary hypertension, so you have to, that will have a bearing on post-operative recovery. So I just want to tell you a story of Dr. Tandon, who in the mid-70s sent out 780 patients to closed mitral valvotomy based on clinical evaluation alone. Pre-echo era, it's considered you can't get information on the mitral valve by catheterizing the patient. So he used his ears, stethoscope, and kept a record of 780 patients consecutively sent for closed mitral valvotomy, surgical closed mitral valvotomy, based on his auscultation. And except for 2 instances, he didn't make a mistake. All the patients did well, except for 2 instances. So it was a remarkable performance. And that kind of quality is possible because